All right, so good afternoon, class. Myself, Dr. Vishpreet, will be looking at complications post myocardial infarctions months past, and we're going to also look at diastolic dysfunction that will lead to heart failure.
Let's take a recap on myocardial infarction, also known as heart attack.
Here you can see one of your arteries in cross-section with an atherosclerosis plaque which has developed over the years. Thrombosis occurs following a sudden rupture of this plaque. A clot of blood has blocked the coronary artery. It prevents blood and oxygen from reaching the part of the heart irrigated by this artery. This part of the heart, already injured, risks being completely destroyed without immediate intervention.
So let's take a look at ventricular aneurysm. A left ventricular aneurysm typically develops weeks to months after an MI, myocardial infarction. So the sequence leading to aneurysm formation involves a combination of structural weakening, mechanical stress, and impaired repair mechanisms in the infarcted area. Initial infarction and tissue weakening. After an MI, the affected area of the heart undergoes necrosis due to oxygen deprivation, leading to the death of cardiomyocytes, which are the heart muscle cells. In the days following the infarction, phagocytic cells like macrophages begin to clear out the necrotic tissue. This clearance process, while essential for repair, also thins the ventricular wall and weakens it structurally. The wall becomes more prone to deformation due to reduced muscle mass and loss of contractile function in the infarcted region. Let's look at Laplace law. So according to Laplace law, wall tension in a spherical structure like the heart is directly proportional to the radius and pressure. So with an increase in muscle mass at the infarcted site, the ventricular radius increases to compensate, and this expansion heightens wall tension in the weakened area. So basically, as the heart pumps, systolic pressure causes stretching in the non-contractile area of the infarct. Over time, this repeated stretching results in a localized outward bulge known as aneurysm. Next, scar formation, also known as fibrotic scar formation. So as part of the healing process, the infarcted area becomes more fibrotic, microscopic change, creating a scar tissue, macroscopic change. However, the scar tissue lacks the elasticity and contractile ability of healthy myocardium. Although this fibrotic wall helps contain the weakened area, it continues to bulge outward with each heartbeat, particularly during systole. This is referred to as dyskinesis, where the aneurysmal segment moves abnormally or balloons outward instead of contracting. Next, we're going to look at the consequences of the left ventricular aneurysm. Great. So the first one. So we have to understand exactly what we're talking about when we mention the consequences. While a true ventricular aneurysm does not usually rupture because it is contained by fibrotic scar tissue, it can lead to several severe complications due to the altered dynamics and electrical activity of the heart. The first consequence that we have is reduced pump function equals heart failure. So the aneurysmal area lacks the ability to contract effectively, which decreases the heart's overall pumping capacity. Blood that enters the aneurysmal segment is essentially wasted as it doesn't contribute to forward cardiac output. Then over time, this reduction in effective stroke volume and cardiac output can contribute to heart failure. Symptoms include fatigue, shortness of breath, and poor exercise tolerance. Second point, mural thrombus formation and embolic risk. So the aneurysmal area often has stagnant blood flow, which promotes the formation of a mural thrombus, a clot attached to the heart wall. This clot can dislodge and travel as an embolus to other organs, potentially causing life-threatening complications such as stroke, renal infarctions, or limb ischemia. The risk of embolization makes it essential to monitor patients with an LV aneurysm and, if necessary, provide anticoagulation therapy to reduce thromboembolic risk. The third point, ventricular arrhythmias. So the stretch and remodel myofibers in the aneurysmal segment disrupt the normal electrical conduction within the heart. This can create electrophysiological abnormalities, increasing the risk of arrhythmias, including ventricular tachycardia and ventricular fibrillation. These can be life-threatening and are a significant cause of morbidity and mortality in patients with a post-MI aneurysm. So let's look at the diagnostic indicators. The first one we have is a persistent ST segment elevation on the ECG. So unlike the transient ST elevation that typically resolves after an acute MI, persistent elevation weeks after the event suggests aneurysmal changes. Next, imaging such as a chest X-ray and a echocardiography of dyskinetic motion. So with imaging, a blue on the left ventricular order can often be seen on the chest radiography, and echocardiography can provide a more detailed view showing the dyskinetic or aneurysmal movement on the left ventricle.
All right, so the second complication once past myocardial infarction is the mural thrombus, specifically in the left ventricle. So the formation of the left ventricular thrombus is a known complication that follows acute myocardial infarction, AMI, particularly in cases of anterior infarcts or large infarctions where the affected ventricular segment is weakened and prone to dyskinesis. Dyskinesis is basically when there's movement disorders, specifically in involuntary muscles. Now, although advances in reperfusion therapy have reduced the overall incidence of the left ventricular thrombus, it remains a significant risk in patients with reduced ejection fraction (LVEF) and wall motion abnormalities post-acute myocardial infarction. The pathogenesis of the left ventricular mural thrombus is rooted in Virchow's triad, which describes three primary factors that contribute to thrombosis: endothelial injury, blood stasis, and hypercoagulability. Now let's go into endothelial injury a bit. So myocardial infarction causes necrosis of the myocardium, resulting in the regional thinning and dilation of the infarcted ventricular wall. Now this injury to the endothelial lining exposes subendothelial structures, including collagen, to circulating blood, promoting a prothrombotic state. The infarct zone becomes a site of inflammation, releasing pro-inflammatory cytokines and increasing tissue factors, all of which promote thrombus formation. Now, blood stasis. The formation of a left ventricular thrombus is heavily influenced by impaired ventricular function and the resultant stasis of blood within the left ventricle. In the presence of In the presence of left ventricular dysfunction, particularly with low ejection fraction or dyskinetic segments, example apical aneurysms, abnormal flow patterns emerge. The blood tends to form vortices in these akinetic or dyskinetic regions, which encourages stasis. This environment, combined with poor contractility, allows for blood components to settle and aggregate, creating fertile ground for thrombus formation. The last one in Virchow's triad is hypercoagulability. Now, acute myocardial infarction triggers a systemic hypercoagulable state as part of the body's response to tissue injury. Elevated levels of inflammatory markers, including C-reactive protein, you call them CRPs, and fibrinogen, are common after myocardial infarction, reflecting an enhanced coagulable state. Inflammatory cells, such as neutrophils, they play a role in enhancing thrombotic processes, further compounded by an increase in circulating prothrombotic factors. This state of heightened coagulability can persist for months post-myocardial infarction, contributing to the risk of thrombus formation after the acute phase. This factor is the reason why it's a complication months past the infarction. Alright, so we'll continue on mural thrombosis in the left ventricle, and now we're going to move to thrombus characteristics and embolic risk. That's at the middle of the slide at the bottom. So the morphology of the thrombus is an important determinant of its embolic potential. Thrombi that are large, protruding into the ventricular cavity, or mobile are more likely to embolize compared to smaller laminar thrombi that are sessile and adhere more closely to the ventricular wall. As thrombus forms in a region of slow or stagnant blood flow, fibrin cross-links with platelets and erythrocytes to create a stable clot. Over time, thrombi may undergo organization, becoming more fibrotic and less prone to embolization as they become incorporated into the ventricular wall. Let's move on to management implications. That's at the top left. Given the high risk of embolic events associated with left ventricular thrombus, particularly in early phase post-acute myocardial infarction, anticoagulation therapy is often recommended. Vitamin K antagonists, we call them VKAs, have been the traditional choice for managing left ventricular thrombus to prevent embolic complications, giving their effectiveness in reducing fibrin-based clot formation. Direct oral anticoagulants, you call them DOACs, are sometimes considered, though they are less established in this context and come with an increased bleeding risk when combined with antiplatelet therapy as required in patients undergoing PCI or with other indications for antiplatelet use. PCIs are percutaneous coronary interventions. Next up is imaging and detection for risk stratification. That's center of the slide. So cardiac magnetic resonance, CMRs, imaging is currently the most sensitive tool for detecting left ventricular thrombus. particularly for small laminar thrombi that may be missed on transthoracic echocardiography (TTE). The cardiac magnetic resonance allows for precise visualizations of the thrombus and the infarcted myocardium, providing valuable information on the thrombus size, location, and morphology, all of which inform risk stratification and management decisions. The transthoracic echocardiography, it remains widely used for its accessibility, but has a lower sensitivity, particularly in cases of small or mural thrombi. On the diagram here on the left, you see a comparison of the cardiac magnetic resonance as well as two versions of the transthoracic echocardiography. And at the top you have a description whereby the acute thrombus you see a protruding apical mass, while the chronic thrombus you would see a smooth laminar apical mass. The diagram on the far left it just shows how the blood stasis actually happens and its location on the infarcted myocardium. Now, another complication months past myocardial infarction is called Dressel syndromes. Now, Dressel syndrome, also known as post-myocardial infarction syndrome, is a rare and delayed immune-mediated complication of myocardial infarction that typically presents weeks to months after the initial cardiac event. It manifests as secondary pericarditis, which is an inflammatory response affecting the pericardium of the heart. The pericardium, as we mentioned earlier in the video, is the fibroelastic sac surrounding the heart. And this pericarditis is often with or without pericardial effusion. The exact mechanism of Dressel syndrome remains incompletely understood, but it is widely accepted to be an autoimmune response. After a myocardial infarction, the damage of myocardial cells and exposure of intracellular antigens from the injured myocardium or pericardium may trigger an immune response. The immune system identifies these exposed antigens as foreign and mounts a response, producing autoantibodies, you call them anti-myocardial antibodies, that subsequently attack myocardial and pericardial tissues. This immune activation is believed to be responsible for the inflammatory syndrome characteristic of Dressel syndrome. The syndrome is a part of a larger group of post-cardiac injury syndromes, which also includes post-pericardiotomy syndrome, that's after cardiac surgery, or post-traumatic pericarditis, that's from blunt or penetrating trauma. Each condition involves an initial injury to the myocardium or pericardium, which initiates a delayed inflammatory response. Now, typically with Dressel syndrome, it develops between 1 to 6 weeks post the myocardial infarction, although the symptoms may appear as early as a few days or late as several months. Now for the clinical manifestations. The hallmark symptoms of Dressel syndrome include the pleuritic chest pain, and that can be described as sharp pleuritic, meaning worsened with deepening breath, and sometimes radiating to the shoulders or neck, indicative of pericardial inflammation. Fever. A low-grade fever is common and results from systemic inflammation. Pericardial friction rub. An audible scratchy sound heard on the auscultation, which occurs when the inflamed pericardial layers rub against each other. Alright, sorry about that. So the auscultation I was talking about is basically when they use a stethoscope to listen to the sounds of the internal organs. So when they use a stethoscope, they would hear a grinding sound of the pericardial friction rub. The next one is dyspnea, and it's often due to pleuritic pain and possible pericardial or pleural effusions. And then the last one, you may have general malaise and arthralgia. These are non-specific symptoms and are likely due to the underlying inflammatory process. Now, patients also commonly present with elevated inflammatory markers such as leukocytosis and elevated erythrocyte sedimentation rate, that's abbreviated ESR, and elevated C-reactive protein, I mentioned this earlier, CRPs. There may be signs of pericardial effusion on imaging, and inflammation sometimes extends to the pleura, causing pleuropericarditis. You allow me, buddy, you allow me. Continuing on with Dressel syndrome, we have diagnostic imaging now. So the diagnosis of Dressel syndrome is primarily clinical, supported by imaging and laboratory findings. First, we have the echocardiogram. So this is the gold standard imaging tool for assessing pericardial effusion and any resultant cardiac tamponade. Next is the electrocardiogram, ECGs. They show diffuse ST segment elevation and possibly T wave inversion, similar to other forms of pericarditis. Low QRS voltage and electrical alternance may be observed if there is a large effusion. You can observe, so the first diagram there, at the bottom left, that shows the echocardiogram. The center diagram shows the ECG. Oh my, I forgot what you call these waves. Anyways, the echocardiogram, okay? Yes. From the electrical impulses of the heart, yes, that's it. And next up is chest x-rays, and that's the third diagram. So the chest x-rays, they can reveal enlarged cardiac silhouette if the pericardial effusion is significant. The next diagnostic imaging is the lab test, and if they find elevated ESR levels, remember ESR is ESR is a measurement for erythrocyte sedimentation rate, and also test for CRP levels, which are elevated. Look for elevation actually, so it's elevated C-reactive proteins. They also check for leukocytosis, which are all indicative of systemic inflammation. Antimyocardial antibodies may be detected, although they are not routinely tested for the clinical practice. Moving on with Dressel syndrome, we have treatment. So most cases of Dressel syndrome are managed conservatively with anti-inflammatory medications. Excuse me. These treatments include non-steroidal anti-inflammatory drugs, NSAIDs, like aspirin, ibuprofen, or naproxen, which are first-line treatments to alleviate the inflammation and the pain. Then we have the corticosteroids. So in cases where the patients are unresponsive to the NSAIDs, you have a short course of corticosteroids such as prednisone, which may be prescribed and gradually tapered over 4 to 6 weeks. Then you have colchicine, sometimes used as an adjunct in patients with recurrent or refractory symptoms, as it has shown benefits in reducing pericarditis symptoms. In cases where there is large pericardial effusion with risk of tamponade, pericardiocentesis, which is a drainage of the pericardial fluid, may be necessary to relieve pressure on the heart. Severe cases may require inpatient monitoring to manage complications and intravenous immunoglobulin therapy, which may be considered in resistant or recurrent cases. Let's go over to the right now and we talk about complications. Now, if Dressel syndrome is left untreated or inadequately managed, it can lead to severe complications like cardiac tamponade. There's an accumulation of pericardial fluid under pressure, which compresses the heart and impairs cardiac output. Next is constrictive pericarditis, and you'll see these two appearing later in our presentation as diastolic dysfunction. Now, constructive pericarditis is when there's chronic inflammation, which can lead to pericardial thickening and scarring, restricting cardiac filling. Then there's recurrent pericarditis. Dressel syndrome can relapse, especially if corticosteroids are abruptly withdrawn. That's why I said earlier they must be tapered 4 to 6 weeks.
The human heart has 4 chambers. The 2 upper chambers are the atria, and the 2 lower chambers are the ventricles. The interatrial septum separates the 2 atria, and the interventricular septum is the partition between the 2 ventricles. The right atrium and right ventricle are connected through a tricuspid valve. As the name suggests, it has 3 leaflets or cusps. On the other side, the left atrium and ventricle are connected through a bicuspid valve. The bicuspid valve is also called the mitral valve because of its resemblance to a bishop's 2-sided mitre or hat. The leaflets of these atrioventricular valves are connected to fibrous tissue called the chordae tendineae, which in turn are attached to papillary muscles. Contraction and relaxation of these muscles make the valves open and close. There are also valves at the opening of the pulmonary trunk and the aorta. These are called the pulmonary valve and the aortic valve, respectively. Because of their crescent moon shape, these 2 valves are also called semilunar valves. The characteristic double-up sound of the heartbeat is produced during the closing of the heart valves. The thickness of the walls of the 4 heart chambers varies with their functions. The walls of the atria are thinner than those of the ventricles, as the blood needs to be pumped into adjacent ventricles only. The left ventricle pumps blood a greater distance at higher pressure. Therefore, the wall of the left ventricle is thicker than that of the right ventricle. The sinoatrial node, atrioventricular node, bundle of HIS and Purkinje fibers represent the specialized cardiac tissue. These fibers are autoexcitable as they have the potential to generate electrical activity without any external stimuli. This makes the heart beat continuously.
Now let's take a recap on the cardiac cycle.
Today's topic is the cardiac cycle. The cardiac cycle describes
So we're going to continue the cardiac cycle. We apologize for the technical issue.
Today's topic is the cardiac cycle. The cardiac cycle describes the series of events that occurs during a complete heartbeat, the contraction and the relaxation of both the atria and the ventricle. The atria serve to receive the blood that enters the heart and passes it to the ventricle. One cardiac cycle is completed when the heart fills with blood and the blood is pumped out. The phases of the cardiac cycle are two. The phase during which the heart muscles are relaxed and fill with blood is termed the diastole. The other phase, where there is a contraction and blood pumps out of the heart to the arteries, is termed the systole. As the heart beats, it transports blood to the circulatory system of the body. The cardiac cycle is vital in the proper functioning of the cardiovascular system. The cardiovascular system is made up of the heart and the circulatory system. They transport nutrients and remove toxic substances from the cells in the body. The muscle needed to pump blood throughout the body is also supplied by the cardiac cycle. The following describes the event that occurs during a cardiac cycle. At the beginning of the diastole period, the atria and ventricles relax and the atrioventricular valves, or AV, open. The oxygen-starved blood returning from the circulatory system passes through the vena cava, the two largest veins in the body, into the right atrium. Simultaneously, the oxygen-starved blood returning from the circulatory system passes through the pulmonary veins and fills the left atrium. The open atrioventricular valves aid the unstrained flow of blood from the atria to the ventricles. The motion from the sinoatrial node, known as the pacemaker of the heart that coordinates contraction, send waves that trigger both atria to contract. The contraction spurs the right atrium to empty its content into the right ventricle, and at the same time, the left atrium empties its content into the left ventricle. The valve between the right atrium and the right ventricle, the tricuspid valve, prevents blood from flowing back into the right atrium. The valve between the left atrium and the left ventricle, the mitral valve, prevents blood from flowing back into the left atrium. These processes are called the first and second diastole period. The systole. During the systole period, the right ventricle fills with blood transported from the right atrium. The left ventricle also fills with blood transported from the left atrium. Fiber branches carrying electrical impulse sends impulses to the ventricles, causing them to contract. This causes the atrioventricular valves to close. The semilunar valve, located between the pulmonary and the right ventricle, and between the aorta and the left ventricle, opens. The contraction of the ventricles allows oxygen-starved blood from the right ventricle to be pumped to the pulmonary artery, and oxygenated blood in the left ventricle is pumped to the aorta. The pulmonary valve, when closed, prevents blood to flow back to the right ventricle. The aortic valve, when closed, prevents blood to flow back to the left ventricle. The pulmonary artery carries the oxygen-starved blood to the lungs through the pulmonary circuit. The blood picks up oxygen in the lungs, where it is then transported back to the left atrium through the veins. The aorta serves the oxygenated blood to all parts of the body. After its tour through the body, oxygen-starved blood is then returned to the heart through the vena cava. These processes are called the first and the second systole period. Thank you for watching our video. Please do not forget to like and share the video. Also, today's topic is the cardiac cycle. The cardiac cycle
This introduces the second half of our presentation, which is manifestations resulting in diastolic dysfunction, which can then relapse into heart failure. So diastolic dysfunction is when there is preserved ejection fraction, and that can happen because of several means of where there's impaired diastolic filling. This can be from left ventricular hypertrophy, restrictive cardiomyopathy, myocardial fibrosis, transient myocardial ischemia, and pericardial constriction or tamponade. In this presentation, this half of the presentation, we'll look at left ventricular hypertrophy, restrictive cardiomyopathy, we're going to look at myocardial fibrosis, and we're going to look at cardiac tamponade. So let's get into it.
So now we're going to look at restrictive cardiomyopathy. So restrictive cardiomyopathy, also known as RCM, is characterized by the heart's ventricles being abnormally rigid, but not necessarily thickened, leading to an impaired diastolic filling. While systolic function may remain normal or near normal, the key problem with RCM is the inability of the ventricles to relax and feel appropriate during diastole, ultimately leading to heart failure. So the most common cause of RCM, restrictive cardiomyopathy, especially in non-tropical countries, is cardiac amyloidosis, which is the deposition of amyloid fibrils that interfere with the normal cardiac structure and function. So let's look at the pathophysiology of RCM. First one, myocardial infiltration. So the primary cause of RCM include the infiltrations of abnormal substances, such as amyloid fibrils, into the myocardial tissue, or deposition of substances like iron in hemochromatosis within the myocyte. So this this infiltration actually disrupts the normal myocardial architecture. Next, fibrosis. So the inflammation process, such as those seen in sarcoidosis or post-radiation therapy, lead to myocardial fibrosis. This fibrosis also contributes to the reduced compliance of the ventricles. So last but not least, decreased compliance. The infiltrated myocardium becomes less distensible, leading to an upward shift of the passive ventricular filling curve. Consequently, this results in increased diastolic pressures and impaired filling of the ventricles. The next point is elevated diastolic pressures. As the compliance of the ventricles decreases, diastolic pressure rises significantly. This elevation causes two major consequences. The first one is a high atrial pressure. High atrial pressure, so the left and right atria experience increased pressures, leading to biatrial enlargement. The left atrium in particular is subjected to elevated pressures due to its role in receiving blood from the pulmonary veins. This enlargement can be observed via the echocardiography. And the second major consequence is the pulmonary and systemic congestion. The elevated pressures in the atria are transmitted backward into the pulmonary and systemic venous system, causing signs of heart failure such as jugular venous distension, peripheral edema, and ascites, also hepatomegaly. Last but not least, diastolic dysfunction. So in RCM, the primary abnormality is diastolic dysfunction. During diastole, the ventricles cannot accommodate the returning blood volume due to their rigid structure. The inability to fill adequately during diastole leads to reduced stroke volume and cardiac output. This manifests clinically as fatigue, decreased exercise tolerance, and symptoms consistent with heart failure. The echocardiographic findings often reveal a restrictive filling pattern characterized by rapid early filling, followed by an abrupt cessation of flow, resulting in a characteristic restrictive pattern. So atrial enlargement and heart failure. We have a look at biatrial enlargement. So due to the high pressure within the ventricles during diastole, the atria must generate increased pressure to push blood into the ventricles. Over time, this sustained pressure overload leads to structural changes in the atrial myocardium, resulting in biatrial enlargement and the atrial fibrillation and deterioration. So atrial fibrillation is characterized by disorganized electrical activity in the atria, leading to ineffective contraction and increased stasis of blood flow. So in RCM, this reduction in atrial contractility can actually lead to further declines in stroke volume and cardiac output, resulting in increased heart failure symptoms and hospitalizations. So continuing, we're going to look at the clinical consequences of RCM. First one, signs of heart failure. So under signs of heart failure, we have two, the right-sided heart failure and also the left-sided heart failure. So now in the right-sided heart failure, symptoms such as jugular venous distension, peripheral edema, and ascites may be prominent due to the systemic congestion. Now in the left-sided heart failure, systems like pulmonary congestion can occur, though they are often less prominent than right-sided symptoms in RCM. So another clinical consequence is reduced exercise tolerance. As the heart struggles to meet the body's demands, patients may experience fatigue and decreased exercise capacity. Last but not least, complications. Arrhythmias. Patients with RCM are at a high risk of this disease due to the atrial enlargement, which can lead to thromboembolic events and progression of heart failure. The chronic nature of the diastolic dysfunction, compounded by arrhythmias and structural changes in the heart, actually leads to a, let's say, a progressive decline in cardiac function. Next, we're going to look at the diagnosis and management. Diagnosis. So the diagnosis of RCM often involves echocardiography, which shows biatrial enlargement and a restrictive filling pattern. Cardiac MRI may also help characterize myocardial inflammations or the fibrosis, while endomyocardial biopsy can confirm the underlying cause. Next, management. So the treatment focuses on symptom relief and addressing the underlying cause. So diuretics may help manage congestion, while weight control of atrial fibrillation is crucial to optimize diastolic filling. In cases of cardiac amyloidosis, disease-modifying therapies may be available. Great. So now we're going to look at constrictive My apologies. My apologies. So now we're going to look at constrictive pericarditis, CP. Okay, so basically, constrictive pericarditis is a condition characterized by a rigid and thickened pericardial sac that restricts the normal filling of the heart, which leads to significant diastolic dysfunction and eventually heart failure. So let's look at the etiology and pathogenesis of CP, constrictive pericarditis. So CP can follow an episode of acute pericarditis, which can arise from various causes, including viral infections, tuberculosis, autoimmune disorders, or radiation therapy after an acute inflammation process. Instead of resorbing, the pericardial effusion organizes, leading to fibrous scar formation and sometimes calcification of the pericardial lid. So this now results in a rigid pericardium that encases the heart and impairs its ability to actually fill properly during diastole. Now, in constrictive pericarditis, the major pathophysiology abnormality occurs during the diastolic phase of the cardiac cycle. During this phase, the ventricles are supposed to be filled with blood. However, the rigid pericardium restricts this filling. So now as blood flows from the right atrium into the right ventricle, the ventricle expands until it reaches limit imposed by the constricting pericardium. Okay, so this now results in a sudden halt in further filling, leading to elevated right atrial pressure. So the impaired filling of the right ventricle leads to increased systemic venous pressure. As the pressure rises, it causes a backup of blood in the systemic venous system, leading to a characteristic clinical feature of CP. So one of the clinical feature is jugular venous pressure, known as JVP. So the increased pressure in the right atrium is transmitted back to the jugular veins, causing them to distend, particularly when the patient is sitting up at a 45-degree angle. The next one is a peripheral edema. So in the peripheral edema, elevated venous pressures lead to transudation of fluid into the interstitial space, resulting in peripheral edema, particularly in the lower extremities. Next, ascites. Increased systemic venous pressure also causes fluid to accumulate in the peritoneal cavity, leading to ascites. This can be mistaken for liver cirrhosis. Next, pleural effusion. Now, in pleural effusion, the venous pressure increases, and this can lead to fluid accumulation in the pleural space, contributing to respiratory symptoms. So the inability of the left ventricle to fill adequately during diastole due to pericardial constriction actually leads to the reduction in stroke volume. Consequently, this results in decreased cardiac output, which manifests clinically as fatigue and weakness and hypotension. So let's look at the physiological compensations and complications. The first one is Kussmaul's sign. So unlike normal physiology, where the jugular venous pressure decreases during inspiration. In CP, the rigid pericardium prevents adequate right ventricular filling during inspiration. This leads to an increase in jugular venous pressure during inhalation, known as Kutzmal sign. This is due to the inability of the right heart to accommodate increased venous return, leading to more pronounced venous distension. Another one is actually cardiac knock. So a characteristic sound of a knock may be heard on examination, signifying the abrupt cessation of ventricular filling when the limits of the pericardium are reached. So now over time, the combined effects of elevated system venous pressure, inadequate cardiac output, and fluid retention lead to congestive heart failure. Patients may present with features such as autotonia, paroxysmal nocturnal dystonia, and overall reduced exercise tolerance. So we're going to look at the diagnosis now. Clinical evaluation. So patients typically present with symptoms of heart failure, including fatigue, edema, ascites, and shortness of breath. Physical examination may reveal elevated jugular venous pressure, peripheral edema, and a characteristic early diastolic knock. We can also have imaging under diagnosis in terms of chest X-ray, echocardiograph, and CT MRI. So under the chest X-ray, so the chest X-ray may show a normal or slightly enlarged cardiac silhouette. Calcification of the pericardium can be noted in chronic cases. The echocardiography, this is the most commonly used tool, which may reveal thickened pericardium, small ventricular cavities, and an abrupt cessation of diastolic filling. And the CT or the MRI shows a detailed pericardial thickness, and it confirms the constriction. Treatment. So 2 ways: medical management or surgical intervention, which is a pericardiotomy. So medical management. So diuretics may be used to manage fluid retention, alleviating symptoms of heart failure such as peripheral edema and ascites. However, they do not address the underlying cause of constriction. And in surgical intervention, this is the definition treatment of constrictive pericarditis. The surgical removal of the pericardium allows for the restoration of normal cardiac filling dynamics. Okay, so the best outcomes in the idiopathic or post-viral cases.
Hello again, it's Jal by Balram. So I will take you through cardiac tamponade. Now in cardiac tamponade, there's an excessive accumulation of fluid within the pericardial sac of the heart, and it exerts pressure on the organ, significantly impeding its ability to fill properly during diastole. The condition leads to a hallmark feature like hypotension, jugular venous distension, and pulsus paradoxus, along with poor urine output, all of which reflects the heart's impaired function and eventually progression towards heart failure. Now let's look at the pathophysiology of cardiac tamponade and diastolic dysfunction. So in tamponade, the rapid or excessive accumulation of fluid within the pericardial sac creates a high pressure, and it surrounds the heart. So this increased intrapericardial pressure compresses the cardiac chambers, especially the right-sided ones, which have thinner walls and are more susceptible to compression. Due to this compression, the diastolic pressure within each chamber rises and equilibrates with pericardial pressure. This pressure equilibration across all chambers, the atria and the ventricles, restricts the ventricular expansion during diastole, severely limiting the heart's capacity to fill with blood. How does this impact diastolic filling? As the ventricles fail to expand fully, diastolic filling becomes compromised, resulting in reduction in stroke volume. Remember, stroke volume is the amount of blood pumped out with each beat. Now with tamponade, diastolic filling is curtailed early in the cycle, leading to rapid elevation in pressure and a corresponding reduction in filling time. This in turn limits cardiac output. Cardiac output is the volume of blood pumped per minute. Now restricted filling increases systemic venous pressure as blood backs up in the venous system, causing signs of right-sided heart failure such as jugular venous distension and hepatic congestion. Now, what does the body do to compensate for this? So the body initially responds to the reduced cardiac output with compensatory mechanisms, including sympathetic nervous system activation. This response increases heart rate and contractility in an attempt to maintain adequate tissue perfusion. However, the restricted ventricular filling means these compensations are insufficient, leading to hypotension. As blood flow to the tissues declines, systematic hypoperfusion occurs, impairing oxygen delivery to vital organs and contributing to symptoms of shock in severe cases. The kidneys, as an organ highly sensitive to blood flow reductions, responds by reducing urine output, that's called oliguria, indicative of reduced renal perfusion and reflecting the body's struggle to conserve volume in response to hypotension. You have a nice little diagram here. When the presentation is done, you can stop and read. It actually compares cardiac tamponade to constructive pericarditis, which Shukwita would have already done previously, and it compares how they both the similarity in both of them, how they manifest pathophysiologically in the body. And then you also below that you have a nice little diagram to understand tamponade by itself. So yeah, let's move into now the key features of cardiac tamponade in diastolic dysfunction. Before I get into the diagnosis and path to heart failure management, I just want to lament one more time the key features, which is that I would do the key features of cardiac tamponade. So there's three main ones. You have jugular venous distension, then you have pulsus paradoxus, and you have poor urine output. I'll go into each one again one more time. So the elevated jugular venous pressure is a direct result of impaired diastolic filling in tamponade. So since the heart is unable to accommodate the usual venous return, blood backs up in the systemic venous circulation manifested as distended jugular veins. This sign is particularly significant in tamponade as venous pressure elevation indicates an inability of the right atrium to empty into the compressed right ventricle, reinforcing the role of diastolic dysfunction in venous congestion. Next is pulsus paradoxus. So pulsus paradoxus is a drop in systolic blood pressure of more than 10 millimeters per mercury during inspiration. So this is a key diagnostic feature of tamponade. The phenomenon is an exaggerated physiological response due to the limited space within the compressed heart. During inspiration, the thoracic cavity expands, creating a negative pressure that enhances venous return to the right atrium and right ventricle. In a healthy heart, the septum shifts slightly to accommodate the increased right-sided filling. temporarily reducing left ventricular filling and causing a slight decrease in systolic blood pressure. Now in tamponade, both ventricles are restricted within a confined fixed volume due to pericardial compression, and the right ventricle's expansion during inspiration further pushes the interventricular septum towards the left, significantly reducing left ventricular filling and leading to a more pronounced drop in the systolic blood pressure. Poor urine output. So reduced urine output in tamponade is an indicator of decreased renal perfusion due to low cardiac output. As diastolic filling and stroke volume are limited, systemic blood flow diminishes, which in turn reduces renal blood flow. The kidneys respond, stupid kidney again, responds by decreasing urine production in an attempt to preserve intravascular volume, a mechanism often seen in low output states as the body prioritizes perfusion to vital organs. Now let's get into this on this slide. Now, before we go to diagnosis, let's talk about how can this thing actually trip us into heart failure. So the progression of cardiac tamponade leads directly to heart failure due to persistent limitations on diastolic filling and overall cardiac output. Increased systemic and pulmonary venous pressures. So now, with the ventricle's inability to fill adequately, systemic and pulmonary venous pressures rise, producing signs of congestion. Systemic venous congestion manifests as jugular venous distension, which we just talked about, and peripheral edema, if the tamponade develops slowly over time, that is. So the pulmonary congestion can lead to shortness of breath and in severe cases, pulmonary edema. Next is reduced stroke volume and cardiac output. So the restriction on the diastolic filling means that the heart cannot effectively increase stroke volume, which severely limits cardiac output. Over time, the reduced forward flow results in systemic hypoperfusion, further exacerbating symptoms of heart failure. Second to last is end organ hypoperfusion. So as the cardiac tamponade progresses and hypertension worsens, vital organs including the brain, kidneys, and liver receive inadequate blood supply. In the kidneys now, this leads to oliguria, which is low urine output, and it may progress to acute kidney injury if the tamponade is not relieved. The brain may also be affected, resulting in mental confusion, agitation, and syncope in advanced stages. Last is compensatory mechanisms fail. So initially, the compensatory mechanisms, including the increased heart rate, the peripheral vasoconstriction, is an attempt to maintain tissue perfusion. However, a sustained limitation on diastolic filling eventually overwhelms these responses, leading to hypertension and decompensated heart failure. And you're dead. Anyways, let's get into diagnosis. So I know I'm kind of explaining it a bit more disoriented from the screen, is because I try to fit everything on one slide, because when it's extended it gets very confusing. So diagnosis now. You have three main diagnoses. You have echocardiography, you have clinical signs, and you have cardiac catheterization. Echocardiography. So this is the primary imaging tool to confirm tamponade, revealing pericardial effusion and signs like collapse of the right atrium and ventricular and the ventricle during diastole. You have a picture there in the center with the echocardiograph. Here. Clinical signs. Some key findings may include hypotension, jugular venous distension, pulsus paradoxus, and so those are the three main ones actually. Yeah, those are the three main ones. And remember, all of these were all discussed just before. So these key features of cardiac tamponade, this is what you actually look for diagnosing it, right? And then last one is cardiac catheterization. So it's used in uncertain cases when you don't really know if it's tamponade or not. And it's used to actually measure equalized diastolic pressures in all the chambers, which is diagnostic of the tamponade. And now to the right of the screen, we're going to look at management. First management method is pericardiocentesis. This is immediate drainage of the pericardial fluid via needle insertion into the pericardial space to relieve pressure on the heart. I would have mentioned pericardiocentesis previously. Now, there's a second method of pericardial window, which is a surgical procedure for recurrent effusions, creating a small opening on the pericardium, allowing for continuous fluid drainage. The next one is supportive care. This includes fluid resuscitation to maintain blood pressure while preparing for definitive treatment, right? So this is more like to slow down the effects until the patient decides or until the physicians decide how they're really gonna tackle fixing this thing. There's a beautiful table at the bottom there that compares constructive pericarditis, cardiac tamponade, and liver cirrhosis, which doesn't directly relate it to the heart failure. But remember, all the organs, they start to try to compensate for the key features that are expected in cardiac tamponade because the body tries to maintain homeostasis. So the table includes liver cirrhosis because you can see compared to that physiological disease, you could say it's a disease. It's a disease. You can compare it to these heart disease. Yep. So now we're gonna go into I forgot. Let me just switch the slide. Yes, as I was saying. So after load, it refers to the resistance of the left ventricle, the resistance that the left ventricle must overcome to eject blood during systole. The left ventricle compensates for this heightened afterload by undergoing hypertrophy, which is thickening of the muscle wall, and this adaptation helps to maintain cardiac output despite increased workload. Next is increased stiffness and diastolic dysfunction. So, hypertrophy alters the structural and functional properties of the myocardium. The excessive growth of myocytes and deposition of extracellular matrix components, particularly collagen, increase myocardial stiffness. The stiffened left ventricle cannot relax effectively during diastole, leading to elevated left ventricular filling pressure. As the ventricle struggles to accommodate the incoming blood, pressures in the left atrium and pulmonary circulation rise, which can result in pulmonary congestion and symptoms of heart failure. A hallmark of diastolic dysfunction is the presence of an S4 heart sound, and this is also known as an atrial gallop. So it indicates that the left atrium is contracting against stiffened left ventricle, contributing further to elevated filling pressures and impaired diastolic filling. In many patients with left ventricular hypertrophy, the systolic function, which is the ability of the heart to contract and pump blood, it remains relatively intact, leading to preserved ejection fraction. However, this does not imply overall heart health. Rather, it indicates a failure to properly fill the heart during diastole. The stiffened myocardium due to hypertrophy leads to impaired myocardial relaxation, a critical component of diastolic filling. Effective relaxation is necessary for adequate filling of the ventricles, and the impairment causes an increased dependency on atrial contraction to push blood into the ventricle. Now, progression to heart failure. As diastolic function deteriorates, the pressures within the left ventricle and left atrium rises. This can result in symptoms such as exertional dysphonia, which is shortness of breath, orthopnea, which is difficulty breathing while lying down, and paroxysmal nocturnal dyspnea, which is a sudden shortness of breath at night. And this would conclude our presentation. Myself and Shawita, thank you for your time, and I apologize for my speech impediment and the amount of talking I had to do. Yeah, but I hope you guys learned something, and thank you.